Hi, everyone, and good afternoon or morning, wherever you might be. My name is Beth Burry Jackson. I'm a Senior Vice President of Clinically Integrated Services at Sedgwick, and I have my colleague Kim Culver here today with me to talk about a roadmap to support COVID long haul cases. Hi, Kim.
Hi, thanks, Beth. My name is Kim Culver. I am the clinical director for pharmacy over clinical support and operations for our pharmacy program at Sedgwick.
Well, we're going to kick off our session today by talking a little bit about long haul COVID. And I think that we all have heard that terminology. We've read about it. There have been a number of discussions about it, especially in the past several months. But we wanted to talk a little bit more about some of the trends that we've been seeing as the pandemic has gone on. As many of you might know, long haul or long COVID, it is an umbrella term essentially. It includes a lot of different reoccurring symptoms, and it might happen after an individual has tested negative. It may be an ebb and flow. Ultimately, it's very hard to define, and that's one of the things that we're going to talk about today. Typically, we see it lasting over 4 weeks, and it can persist up to over a year. We know also that in many of these cases, we have seen multi-organ complications, or it impairs individuals functionally, and they have difficulty performing day-to-day tasks. It's been interesting in a recent longitudinal of hospital survivors. By and large, the vast majority saw good health outcomes in terms of physical recovery, but what we do know is that generally their health status was significantly lower when compared to the general population. And while only 10% of all patients with COVID-19 might experience these long-term symptoms, we know that that's going to impact the population at large, and it may do so for some time.
So we're often asked why these symptoms persist or who is at risk for long haul COVID. So sticking with our roadmap theme, I would like to review the road hazards, if you will, or risk factors for developing long haul COVID. Advanced age and females are at a higher risk for developing long haul COVID symptoms. We know that individuals can develop long haul COVID that maybe didn't have any symptoms at all with the initial infection. So when they first tested positive, or they may have had mild or moderate symptoms, but those with severe symptoms are at a much higher risk for developing long haul COVID. And those severe symptoms, it's usually 5 or more, and they include things like chest pain, rapid heartbeat or heart palpitations, shortness of breath, brain fog is another one. And what we hear often are individuals are maybe in a conversation and they can't think of the words that they want to use. So it's that type of brain fog. It's like they know it, but then they can't think of it. So those are some of the severe symptoms that we see. And when they have 5 or more of these symptoms, like I said, they are at a much higher risk for developing long haul COVID. Health status prior to COVID-19 can also increase their risk for long haul COVID. So comorbidities such as high blood pressure, asthma, diabetes, obesity, or even chronic smokers, they are at a much higher risk for developing long haul COVID. Oops. There's not a one-size-fits-all treatment for long-haul COVID either, and this is due to the symptoms and the symptom severity that they vary among those that are infected. Currently, there are no standardized guidelines for treatment of long-haul COVID. So this makes it difficult to treat since long-haul COVID symptoms often mirror chronic health conditions. So like asthma, I mentioned previously, or heart conditions even, and high blood pressure. We often see that these individuals are being managed by their primary care physicians who focus on symptom management rather than taking a holistic approach to treatment. So this can lead to overutilization of medications, which can cause additional symptoms due to medication side effects. And it can also lead to excessive time out of work. Long haulers, as we like to call them, they often need referrals to specialists like cardiology or pulmonology or even pulmonary rehab and physical therapy, as well as behavioral health to overcome some of those fears and the anxiety that many develop when they have COVID-19.
Well, for our discussion today, this theme of a roadmap. And what we thought we would do is to give you two scenarios, both individuals who were diagnosed with COVID at different times during the pandemic, and their pathways definitely diverge, their roadmaps, if you will. We think it's an interesting way to look at these cases. We'll do some call outs of things that we think are really important to pay attention to, and to realize, again, as Kim mentioned, there is no one size fits all guideline. We have to make sure that we're looking at each individual as they present their varying symptoms and then addressing those in the most proactive way possible. So Kim, we'll go ahead and get started on our case study on John. John was diagnosed in early 2020, and he was a nurse. He had a patient exposure. So Kim, do you want to talk a little bit about John's situation?
Absolutely. Thanks, Beth. And I'm going to introduce you to John. We're going to walk through his case. And like Beth said, we will point out some of those things that we feel are really important to make note of or to recognize as you're navigating any of these claims. So John is a 48-year-old healthcare employee. He was a nurse who provided care to a patient on March 17th of 2020. On March 18th, that patient that he provided care for was diagnosed with COVID-19. Since John provided care the day before, he did not wear any personal protective equipment or PPE while he was providing care to this patient. 3 days later, John developed symptoms of cough, sore throat, headache, body aches, joint pain, fever, and shortness of breath. 5 days after exposure, his symptoms continued to worsen, so he went to the emergency room to seek medical attention. Due to limited testing supplies, he was diagnosed as presumed positive for COVID-19, as well as pneumonia, and he was discharged home with a prescription for antibiotics and advised to take Tylenol or acetaminophen for fever.
And Kim, I think it's important to, as we're walking through his roadmap, we realized this was early in the pandemic. So there were a lot of measures that didn't take place that perhaps would have normally, instead of being able to go to another facility, say for COVID testing. He actually had to go back into the ER, which of course costs were higher for that visit. And then, naturally we had seen testing shortages as well. And even today, we realize that there can be some delays. So the advisement about this hazard is, ensuring that if we are assuming and presumed positive, testing availability is something that we have to really key in on.
Yes. So let's see what happened to John. So 3 months after he was diagnosed as presumed positive, John had an appointment with his primary care doctor or his PCP. The reason he went in was due to a continued cough. So the ER had told him to make sure to follow up. Like I said, he waited 3 months and he only went because he continued to cough. His primary care doctor treated his lung symptoms with an inhaler and oral medications. These medications that he was prescribed are often prescribed to treat asthma or COPD. So another 3 months goes by. We're now into September, and John's PCP referred him to pulmonology and cardiology because he continued to have symptoms. John's symptoms included shortness of breath, rapid heartbeat, and high blood pressure. John's cardiologist started him on medications to lower his heart rate and his blood pressure, and he did an EKG and some lab tests. The pulmonology, or the lung doctor, continued the medications that the primary care doctor prescribed for asthma symptoms, and the pulmonologist did educate him on the side effects of those medications, but he also ordered pulmonary function tests just to see how his lungs were actually working, that oxygen CO2 exchange. In the documentation from the PCP, the cardiologist, and the pulmonologist, there was nothing to support that these providers were communicating. John's pulmonary function tests were normal, and the pulmonologist, a month later, did an exam, went over those results with John, and discontinued the inhaler and the oral medications. John did continue, though, on the medications prescribed by his cardiologist. So in December, we're now another 3 months out, John had a follow-up with his primary care doctor, and he was complaining that of that chronic fatigue and just that he overall didn't feel well. So John's primary care doctor referred him to a COVID specialist, or a COVID clinic. And at that clinic, at the initial visit, John was diagnosed with a hiatal hernia, headaches, depression, nerve pain, heartburn, urinary changes, as well as sleep disturbance. John left the COVID clinic with 18 additional prescriptions for a monthly cost of over $2,000.
So Kim, I think it's pretty clear in this particular situation, John's roadmap to recovery was diverted a couple of times. And as you mentioned, due to some of the lack of coordination in these early months, it became very clear that there wasn't one provider who was doing all of the coordination. They weren't talking to each other about his symptoms and about things that were developing. I think an important call out that you and I have talked about a number of times when it comes to pharmacy is the impact of all of these medications, 18 in fact, that John was prescribed, and how many of these could have interactions with each other, that in fact, some of the side effects of medications, in the case of the asthma medication, it can also cause symptoms that are similar to COVID-19 symptoms. So in fact, it's very difficult and challenging for physicians, especially if they're not talking to each other, to determine exactly what is causing which symptom and why. And of course, you mentioned his fatigue. That is obviously something that we see. The statistics show us that 50% will actually report fatigue symptoms. But now, whether or not that is, again, due to medications or due to, in fact, long COVID, we don't really know. Of course, you also mentioned that he was referred to a COVID specialist. And I think while we all see those clinics and the different approaches that they're taking, it's important to know that these clinics are not created equally, right? They are not under the same guidelines. They're not regulated per se. And so it's important when you do have a claim in these types of scenarios that you're mindful of the provider's recommendations, and if they are asking, the individual to go to a specialty clinic for long COVID, that we really vet out those situations and ensure that we get the right resources involved from a clinical perspective to address some of these complex medical and complex pharmacy issues.
Absolutely. So what do we do about this, especially with these now all these multiple new diagnoses that John has received? What we did was we requested his medical records from prior to his COVID-19 exposure. These records were received and we were able to establish a baseline health status for him. The record showed that John had pre-existing GERD, explains that hiatal hernia, high blood pressure, coronary artery disease, high cholesterol, obesity. He has a tobacco smoker for 25 years. He has pre-existing anxiety and allergies. So given the complexity of the added health conditions and discrepancies in these pre-existing conditions, an IME was obtained. All right, so the IME provider determined that these diagnoses and treatments prescribed by the COVID Care Clinic were actually for pre-existing conditions. They were not for the compensable injury, so they were not for COVID, long-haul COVID. So the IME provider did opine that the initial treatment by the pulmonologist was appropriate and indicated, but that has resolved, and none of the treatment that was provided by that COVID Care Clinic was related to the COVID-19 diagnosis or the work diagnosis that has been accepted. So again, there was no causal relationship between the treatment received at the COVID clinic and COVID-19. So John was placed at MMI and he was released to return to work.
Yeah, Kim, and again, this points out the importance of earlier intervention. And so I think what we can learn now from, this, again, very early COVID claim from the early part of the pandemic is that going forward, early intervention is key. And if we're looking at how we ensure that we start out on the road to success, and that we avoid some complications on down the way, it's important that we have good documentation, good testing, and avoiding obvious treatment delays. That was a big part of John's map, was that he, in fact, waited a few months and then was directed to a different provider, and then another few months passes by, and then he gets redirected again. We certainly have learned that we want to avoid these treatment silos, that we often recognize that providers of varying specialties may be called in to address the symptoms that the individual is experiencing. And in fact, as Kim mentioned, sometimes these symptoms are not related to the actual COVID infection. And ensuring that we keep things delineated is incredibly important. And if there are multiple providers, that we ensure that there's resources there to avoid the silos of treatment, as we said. So ultimately, as John was released to return to work, we all know that there were certain complexities along the way that we may have been able to divert from had there been the opportunity to intervene. So next, we're going to talk about Mary. Mary was also diagnosed with COVID, but her case was in early April of 2021. So obviously we had a lot more availability of testing and resources by April, but we also know that similarly to John, she's also going to experience some complications of long COVID after her diagnosis in April. So Kim, do you want to talk a little bit about Mary's situation?
Of course. So let me introduce you guys to Mary. Mary is a 53-year-old customer service associate. She developed symptoms including visual changes, brain fog, dizziness, and right lower extremity weakness, as well as back pain in April of 2021, so April of this year. She sought medical attention in the local emergency room and tested positive on a rapid COVID test. She was admitted to the hospital for ongoing care, including supplemental oxygen. After spending 10 days in the hospital, Mary was discharged, and she was instructed to follow up with ophthalmology, neurology, and her primary care physician. So this claim was accepted for COVID-19, and medical records prior to COVID symptoms were requested. 1 week later, or 1 week after her discharge from the hospital, she was seen by ophthalmology, and she was diagnosed with cataracts in both eyes and glaucoma. She was prescribed prescription eye drops for the pressure caused by the glaucoma. Her prior medical records were received, and they were reviewed to establish that baseline health status. Mary was noted to have pre-existing comorbidities of diabetes, anxiety, high blood pressure, depression, memory loss, and obesity. She was also prescribed medications for these conditions. Records from her primary care physician also indicated that Mary had been non-compliant with treatment in the past.
I think, Kim, what this really highlights for us is exactly as you mentioned, underlying health conditions are often brought to light when providers are attempting to delineate exactly what is causing a particular medical problem at a certain point within the course of the treatment planning and the evaluation. And I think that we also realize that a lot of the comorbidities predisposed Mary to long COVID, to have symptoms that would continue. And then ultimately, in establishing early that baseline of what types of medical issues she had prior to COVID-19, it was important in understanding the differences between what she was experiencing and the new symptoms that were developing along the way versus what was actually attributed to the infection itself.
Right. So continuing with Mary, so remember she was diagnosed in April. Well, she went to the ophthalmologist a week later, but in June, prior to her visit with the neurologist, she had a fall. So she fell and she broke her forearm, both bones in her forearm. She reported that the reason she fell was because she continued to have that right lower extremity weakness from COVID-19. So remember, that was one of her initial symptoms. Surgery was not required for her arm, although they did immobilize it for 2 weeks and then referred her to occupational therapy. Mary did follow up with neurology and primary care. The neurologist continued the medications prescribed for nerve pain. That was what was causing her back pain. And the medications were brand medications that were prescribed. There was no indication of trial and failure of first-line generic medications. The primary care provider saw Mary for a hospital follow-up appointment and reported the diabetes and her high blood pressure were exacerbated by COVID, but both had returned to baseline. So no further treatment for COVID symptoms was necessary.
And Kim, I think that's really interesting because now that we know more about the impacts of COVID, it certainly impacts the way that that the body functions. And important to Mary's case was the pre-existing diabetes and high blood pressure, and so certainly her infection impacted the production of insulin, and ultimately with the medications that she was taking, that's really important to review with the physician, and ultimately ensuring that we are able to establish again that baseline level that we want to get back to. You also mentioned the issue of medications, brand name versus generic. Kim, I think in your pharmacy world, you've seen that uh, as a big impact. And certainly as providers who are attempting to treat long COVID are layering these medications, we certainly want to encourage, the reduction of medication, but then, understanding that when we have the opportunity that we want to channel to a generic if possible. Um, Now, in this situation, it was unfortunate, and Mary had a fall during the course of all of this. And again, ensuring that we reduce that time between incident and evaluation and treatment is always imperative. And so, as we have seen with these long COVID cases, ensuring that as additional symptoms or incidents occur, that we address it right away. And in this case, she was able to avoid any type of surgery, and we really needed to get her into a physical therapy program in order to reduce any types of delays in return to work.
So in July, a nurse case manager got involved in Mary's case and assisted with the coordination of Mary returning to work. She scheduled a follow-up with the neurologist and made sure that Mary got in with occupational therapy. And the nurse case manager also scheduled a call with all of the physicians on her case to make sure that there was a coordinated plan of care. Instead of those silos, like we mentioned earlier, Mary did have that coordinated plan with all providers. Mary returned to work with accommodations of no lifting over 10 pounds, and she had accommodations for scheduling flexibility so that she could attend her occupational therapy visits. Mary then developed a significant anxiety and reported high levels of stress upon returning to work. She let her case manager know that her anxiety was really causing her. She was worried about it because of the brain fog and all. Is she going to be able to do a good job? Also, she's been out for a few months, and that's where she was exposed to COVID. So that's where she contracted the virus. So she had a lot of anxiety around going back to work. So Mary worked with her case manager, and they engaged a behavioral health coach to help her develop coping strategies for her stress and anxiety so that she would be able to return to work, but also prevent the need for additional medications. So I'm happy to say on August 4th, which was 4 months after her initial COVID diagnosis, Mary was placed at MMI, and she was returned to work full duty without restrictions. And all of her medications for long haul COVID symptoms were discontinued.
Yeah, Kim, and you brought up some good points about Mary's return to work too, because I think that in and of itself, what we have realized is that return to work is a journey, and it has its own roadmap when it comes to long COVID. We are looking at now statistics across industries where we've seen, and here estimated 68% of employers reported an increase in accommodation requests. And a lot of those requests were work from home requests. We know that, especially in a case like Mary's, where she knows that she had, perhaps an interaction that precipitated her infection at her work site, that she's now hesitant to go back to that same work site. And I think that ensuring that we are attending to the mental health concerns of employees as they're returning to work really helps us develop a plan, whether that's a gradual, modified duty return to work, temporary accommodations to support them. That's really critical these days. And I think that even more so when we've looked at, altered work schedules, 45% of these requests are exactly that, ensuring that we provide some flexibility and knowing that sometimes the symptoms may ebb and flow, but ultimately we need to get in front of any of these issues with anxiety, depression, or even to the extent of real difficulty engaging in work again if someone has a high sense of anxiety or fear about the workplace. So we know that nowadays, especially, mental health is really paramount. We have seen high levels of stress in work environments, especially amongst frontline workers. And we know that frontline workers, first responders, through some of the research that's been done throughout the pandemic, we realize that their challenges are unique. Oftentimes, they haven't been able to work from home. They didn't have an opportunity for that accommodation. And therefore, their constant contact with the public has put even more stress and strain, and they're much, much more likely to have symptoms of anxiety, depression, even substance abuse. And that's something that if you are looking at a claim or you have an employee who has experienced long haul symptoms, the mental health component is something that really needs to be keyed in on here, because we know that that's ultimately going to impact their ability to re-engage on a full-time basis. And we want to be sensitive to those needs. And as you'd mentioned, if it's through behavioral health coaching, EAPs, whatever might be available to the employee to support their mental health, it's a good thing to engage that.
Absolutely. So we've gone down our I guess roadmap here of long haul COVID, and we've identified road hazards, or I like to call them roadblocks, really, along the way. And we hope that you're able to use these to navigate not only COVID claims, but other claims similar to long haul COVID. Early intervention, as well as establishing baseline health status, should be a priority when a COVID claim is accepted. Just for instance, John and Mary. John was out of work for a year. Mary was out of work for 4 months. So I know John was diagnosed in early 2020. That's when the pandemic was new. We were still learning a lot. Like we mentioned, we didn't have those resources that we have now. So we've come a long way, but it's still important that we establish that baseline, and that we get these claimants in to see doctors timely. We want them to not only be compliant, but we want to help them make sure they have access to care. Like Beth mentioned with the mental health aspect of this, Mary was out for 4 months, so it wasn't a whole year, but that anxiety and the stress, it's going to prevent her from doing the job that we want her to do when she returns to work. So getting her those resources that she needs and getting them earlier, rather than waiting until it becomes an issue. Let's get on it early. She has these, we know they're pre-existing, they're exacerbated by everything that she's gone through. So we want to make sure that we make those referrals or get them the help that they need. The pharmaceutical utilization, goes back to John. John was on a respiratory inhaler. With a side effect of that inhaler is increased heart rate. When he went to the cardiologist put him on a medication to decrease his heart rate. Well, again, they were treating in silos. So the pulmonologist And the cardiologist and the primary care doctor, really, they were not communicating. So when the pulmonologist discontinued that inhaler, well, he's no longer on the medication, causing the elevated heart rate. So the cardiologist may have wanted to stop that medication or monitored him, but instead continued the medication. Well, then he starts complaining of fatigue and not feeling well. Well, if you have a low heart rate, a low blood pressure, you're probably not going to feel well. So that's when he was referred to the COVID clinic. So had there been communication, we could have avoided all of that, most likely, and gotten John back to work sooner, and also avoided him feeling so bad. And then, the COVID care clinics, as Beth mentioned, they're not all created equally. We just need to make sure that if the whole purpose of them is, it's kind of like a one-stop shop. You can go to the COVID clinic, and they're going to have the specialists there that may be needed. Well, we just need to make sure that they really do have those specialists, and do our research on these, because they're, like Beth mentioned, they are not regulated. So we do want to make sure that the claimants are getting the best care. So we would want to research those clinics prior to referring.
Yeah, thanks, Kim. I think that really goes to show, there are things that as we look in, not to belabor our roadmap analogy, but we're looking in the rearview mirror now, right, of the pandemic and what we have seen over the course of the past year plus with COVID cases. We've learned a lot throughout. And we know more than we did back in early 2020, for sure. So there are lots of things that we can do during the life of a claim so that we can avoid some of those treatment issues, the pharmacy aspects of it, as well as ensuring that we get behavioral health resources engaged early on so that we can avoid some of the anxiety and issues that resulted. I think that, what Kim and I want to leave you all with is a picture of what is down the road. So what do we project out for the future with long COVID? And as you can imagine, the road is not that clear. Like with a lot of things with COVID, we don't know exactly what is going to happen with individuals who have these long-term impacts of COVID-19. I think what we do know is that managing for the future medical care, especially in severe cases, is really critical. So engaging the right providers, ensuring that we're taking a look at claims in which are turning really catastrophic at this point. We hear circumstances where there are individuals that end up having surgeries and even transplants because of multi-organ failure due to COVID. And they're certainly going to be much more susceptible to continued symptoms on down the line, and ensuring that we address those quickly and having a really strong care plan on those that are going to require future medical. Now, of course, addressing return to work barriers, that's something that we realize now, especially with COVID-19 and long COVID being recognized as a disability. This has increased the complexity of what employers have to deal with, and certainly looking at ways that they may end up accommodating employees who request changes in work schedules or changes in work environments. We know that right now there are a large portion of individuals who are challenged with getting disability benefits due to the complexities and the varying symptoms that they may have due to long COVID. So, we know that it's always a good idea to establish early documentation, but also when it comes to establishing whether or not those long COVID symptoms are in fact creating a qualifying disability. That's important for the individual to perhaps get disability benefits so that we can reduce our exposure on the work comp side. So I think, we're looking way down the road at this point and knowing that we're going to continue to pivot, we're going to continue to change, but early intervention, early documentation is key, and continuing to engage solid clinical resources along the way will set you on a pathway of stronger recovery, especially as we know more and as we've come along the way of the pandemic. So Kim and I are going to be wrapping up our discussion, but certainly if any of the viewers have any questions, feel free to put those into the chat box to the right side of the presentation. We'll be happy to stick around for another minute or so in the event that anyone has questions. All right, Kim, it looks like we don't have any questions from our viewers this afternoon. But again, if anyone should have questions about our presentation, certainly look us up. We'd be happy to speak with any of you. It was great to be here today at the Laude presentation, and we're just appreciative for everybody that attended. So thank you and have a great rest of your day.